doctors in our Department of Internal Medicine at the University of Missouri, and 60% had some sort of positive phonotype. Now, I don't want to scare you guys. I can't explain it all, but it tends to be nonspecific. The setting for neuropsychiatric lupus, well, often the lupus is clearly active, and there's some objective neurologic abnormality, either on your careful neurologic exam and our imaging study. There's something there. Steroid psychosis? Yes, it could be. It's becoming increasingly unusual. The prednisone dose is usually 40 or more milligrams a day. A trial of therapy may be warranted, and here I'm talking about using your judgment to raise or lower the prednisone dose. Some people recommend that you double the prednisone dose for 3 days, and if the patient is starting to improve, well, maybe this was steroid psychosis. Other clinicians have told me that if they have just increased the prednisone or doubled the prednisone, and the patient becomes schizophrenic 2 days later, we may actually be dealing with true steroid psychosis. Your physical exam includes looking for evidence of active disease if a patient comes in with lupus, central nervous system findings, and skin findings like this active vasculitis. We tend to think maybe there's active vasculitis in the brain. Cytoid bodies can be helpful if the patient does not have uncontrolled hypertension or uncontrolled diabetes and yet appears with these fluffy yellow exudates in the retina. This certainly may be compatible with active lupus. Well, so I want to emphasize that it's important to evaluate the patient clinically. In my hospital, there's a tendency, a lupus patient comes in, her disease may be active, she's not acting quite right, she's shipped off immediately for an MRI study. Well, that's fine, that's good. That may help you rule out thickening of the meninges compatible with meningitis or a stroke, but this is not going to tell you always if this is central nervous system lupus. Now, in this T2 Wade image, there are, and I find it extremely hard to spot, especially in the distance, but if you look carefully, there are tiny white areas of increased signal in the white matter, and that's consistent with central nervous system lupus. But this can also be found in lupus patients without central nervous disease, diseases such as multiple sclerosis, Sjogren's, or even atherosclerosis. Now, I'll tell you, it's a real problem when you get a 40-year-old woman who's been smoking a pack or two of cigarettes for the past 20 years who has these findings. It's not necessarily central nervous system lupus. The most common findings are these infiltrates, lymphoid infiltrates. We don't often find gross vasculitis, but it can occur. In this MRI, you see the low intensity signal. There it is. That's compatible with vasculitis or an infarct or even embolism. This kind of picture also should make us think of antiphospholipid antibody syndrome, which has been nicely reviewed for us. Digital gangrene is the one physical finding that does correlate with central nervous system lupus, possibly vasculitis. If it's vasculitis in the fingers, it could be in the brain. When should we treat the patient for neuropsychiatric lupus? Now, from day to day, our lupus patients tell us that they have headaches, many of them are depressed, and they do have periods that I call lupus lapses, in which there is transient loss of memory. Will almost without exception, within the month, develop a really bad complication. what we have done is to start with 12 or 15 milligrams of methylprednisolone given IV Q6 hours to keep a constant flow going. Now, there are a couple of findings that can be confused with CNS lupus. This is hypertensive encephalopathy with symmetrical occipital abnormalities on MRI. And a young woman who came in, very high blood pressure, seizure, and overloaded with fluid. And after she was treated for a week, the finding resolved. Here's another finding that we're beginning to see in the patient with strong, long-standing immunosuppression. And we're seeing it in our lupus and rheumatoid arthritis patients. It's rare, but it's important to know about it. Now, PML is a viral infection of the brain in the immunocompromised patients. It's not Jacob-Creutzfeldt disease. That's different, but it's a JC virus. Now, many of us have it. It's in 75% of adults. We acquire the virus in childhood. It lives in the renal epithelium and is activated in immune suppression, and then it seeds the brain. Subacute beginning, but usually after a period of months or a year, the patient is clearly very sick. The case fatality is reported as 90%. It's close to 100. Many of these patients have HIV infection. Before the era of HIV, they were all cancer patients who'd been treated with immunosuppressive regimens like CHOP, who were very immunosuppressed. But now we're seeing that about 2% are on immunosuppressive therapy and have rheumatic disease. Now, the biologics associated with PML are